so
Yes,
much.
sir.
My apologies to Dr. Ajay sir because of some urgent meeting which is coming up at 5 o'clock with DGHS with COVID-related issue. I had to rush there, so I had requested to jump the queue. My apologies to you. I had the privilege to listen to the previous speaker, Dr. Sarin sir, who has done an excellent job of explaining why NAFLD is important, why it has been decided that it should be integrated with the NPCDCS program. To make it easier for all of us to understand, for many of us who are seeing the program for the first time, particularly the NPCDCS program, I would like to remind that it was long time back in 1975 that India started thinking that we should be responding to the NCD challenges with vertical national program. Then in 2008, we piloted in about 10 districts, and it was decided to increase to about 100 districts in 2010. And then in 2013-14, with the advent of the National Rural Health Mission, which is now known as National Health Mission, it was rolled out to 36 states and UTs. And we had about 468 districts approved in 2015-16. And then the paradigm shift also happened with the comprehensive primary health, care package through the health and wellness centers. Then the arrival of the population-based screening. Then NCD was then integrated with other program as well. And in 2021, we had this integration of NAFLD with the NPCDCS. So this is the, in one snapshot, how we had traveled from 1975 to 2021 without going into the details. The program has got a few objectives like the health promotion through behavior change in our attempt to make ourselves and our citizens healthy. And we also have the second objective of population-based and opportunity screening. Population-based training, what is known as the PBS, happens at the doorstep when the ASHA comes at the doorstep, then enumerates whoever is there in the facility and in the household, and then screen through a community-based assessment checklist. And then whoever needs to be referred are referred higher. And we also have the continuation of the opportunistic screening, where any person who wants to get screened for the NCTs or related risk factors drops into the NCT clinics, and they continue to do that. So we we are continuing both so that we augment each other. And then the third objective is prevention and control of the chronic NCDs, in a way of, trying all kinds of interventions that we have enumerated, starting from that, from the first health promotion to the screening to the management of it. And then we also have the fourth objective of building the capacity in the continuum of care in terms of IEC, in terms of operational research, etc. And then we also support diagnostic and the cost-effective treatment at all levels. So this is happening now through the National Health Mission, where the state sends their state PIPs, and the NPCC meetings decide how much funding according to the demand of the states would be given to that particular state. The infrastructure that we have in order to roll out these activities, continue the activities which we have stated here. We have the national NCD cell in the ministry where I work, and we also have a similar structure at the state NCD cell in all the states now. And then an administrative setup in the district is what we call the district NCD cells, and these are administrative setups which will run the program. And the actual clinical activity happens at the district NCD clinics, which is about 650 now, and the numbers still counting. And we also have the cardiac care units, or the CCUs, which is to take care of the cardiovascular components being established in about 190. And though the whole package has got CCU package in the NHM component of the National Program for Prevention of Cancer, Diabetes, cardiovascular disease, and stroke, what we call the NPCDCS, many states are yet to pick up the CCUs in the districts due to various reasons. One of the main reasons being the non-availability of the cardiologists at the district hospital. And the district daycare centers are those centers which will be utilized for providing, chemotherapy to the cancer patients. This is also one of the components, and the number is about 239 of them. And then below the district, we have got what is known as the CSC NCD clinics, which is about 4,807. And now with the coming of the Ayushman Bharat Health and Wellness Centers, we have got many of them sub-centers and PACs upgraded into health and wellness centers. And also, as I said in the beginning, we have started the NCD services in the form of population-based screening at the doorstep. So this is in brief the structures through which the NPCTCS program is being delivered. So talking more about the population-based screening, all the patients who are about, I won't say patient, or all those persons who are about 30 years of age in the community are being screened for the NCDs through what is known as the community-based assessment checklist, the CBAC. This is now, turning from the paper format to more of the digital format. And then the ASHA is referring as per the score, which is generated from the CBAC form to the ANM, and ANM further screens them and then sends them up wherever required to the medical officer at the primary health center, and then the NCD clinics at the CAC and the district hospital. So the continuum of the PBS is attempting. We are with the continuum of the care in the PBS. We are trying to attempt the doorstep screening till what they require treatment at any level throughout, and then recording this in a digital form in such a way that we can monitor how many patients have dropped in, how many have been diagnosed for hypertension, how many of them have been diagnosed for other cardiovascular diseases or COPDs, or even the BMIs and the height and the weight. So when this is happening, already happening in NPC these years, when Dr. Sarin Saab and all of us here in the ministry started thinking of integrating NAFLD, we wanted to see what actually is already there for in the PBS, which we can use for NAFLD. So this was one of the area which we started thinking. So with NAFLD requirements, we know by now that whatever attempt you are doing for the diabetes, if you don't take care of the fatty liver, the risk of diabetes and vascular complications are not going to be taken care of. Then whatever care you are trying to take care of the CKDs, which we have as one component of NPCTCS in the form of Pradhan Mantri Dialysis program, which is the care of the end-stage renal disease. We cannot take care of that completely if you don't take care of the CKD prevention, and that also points out to the fatty liver as a core issue. And the cardiovascular component, the CCUs that you are trying to establish, if you don't take care of them, take care of the liver, the risk for future stroke as well as the, many other diseases, including hypertension, are not going to be taken care of. So fatty liver, the gallstones, and the cancers are also additional harms which a fatty liver person can develop in better. So Dr. Sarin had explained in detail about this. So the NAFLD, which is the mere build-up of the extra fat in the liver cells, can no longer be associated only with alcohol, can no longer be left out as something normal. Like till now, many people, even among the clinicians, tend to say that we all have some part of fatty liver. Why should we take this seriously? But the time has come that if you don't take care of this, it is going in a downward trend, and then whatever program components that you have in the NPCTCS is not going to be successful if you leave out liver. With these thoughts, what we tried to do was we tried to marry the NCDs with the NAFLD because of the sheer prevalence of the huge prevalence of NCD along with the huge prevalence of NAFLD. So if you take care of the NAFLD, we know very sure that many of the NCDs would be taken care of. So with these thoughts, we try to see when we are doing the risk factors for the NCDs, and the risk factors for NAFLD, we try to match them and see what are the activities where we need to focus. So these are some of the areas where we had already identified, and then we earmark the activities when we do the risk factors for for the NCD. Say, for example, if a family history is being taken by the through the CBEC form by the ASHA, that family history will have significance of NAFLD. Then if physical inactivity is being detected, if unhealthy diet is being detected, if the person is hypertensive, then not just for the mere fact that the person needs treatment for hypertension, we now need to link it with the other factors as a risk factor for NAFLD. And many of them, like the metabolic syndrome, hypercholesterolemia, and obesity and diabetes mellitus type 2 are in fact common risk factor for the NCDs and NAFLD. So our thinking is that when we are taking care of the NCDs, it is only that we are emphasizing more now, because when we take care of some of them, they have got direct relationship with the NAFLD as a risk factor. So with that thinking, I think many of us, with the help of Dr. Sarin's team, particularly Dr. Umesh Kapil sir, we have done a very intensive work in trying to devise an operational guidelines. We finalized the operational guidelines with collaboration of many stakeholders, including NSSRC, the DGHS team here, ILBS, and other development partners like UNDP and WHO. And we have also started having a lot of workshops through webinars, because unless the operational guidelines are made aware, unless the operational guidelines are distributed, disseminated to all the stakeholders, then we may still continue to do many things for NCDs, but it is very likely that NAFLD could be left out. So we are also trying to develop many IEC material with the help of these partners, and also try to do a gap analysis for the diagnosis, treatment, prevention, with particular emphasis to NAFLD in medical colleges, district hospitals, and the CAC. So this is what we have started working in the ministry. This is the picture when the Honorable Health Minister has launched NAFLD, the operational guidelines of NAFLD. And as Dr. Sarin said, we are one proud country which has, liver in the focus. I would like to say here that, when we start exploring working with different partners in NAFLD, I'm surprised to hear from some of our partners saying that this is the first time that NAFLD liver is focused in any of the meetings of my organization. I won't name the organization, but since it is not being taken up at the headquarter level, I'm not sure whether the discussion here for including liver in my work of activities may be taken care of in the right sense. So in a way, I was disheartened saying that they are unable to work there, but in a way, I was also proud that we are doing something which many countries or many organizations at the apex of NCDs have not even started thinking in the right manner as we have done. So we have met the beginning here, and I would be requesting everyone here, to continue to work towards, implementing NAFLD. And we have had much discussions that how do we now implement the operational guidelines. So we tried to develop some strategies, which is not very different from what I had already shared for the NCD. Say, for example, health promotion, screening and early detection, a timely and affordable, accurate diagnosis, and assessment for affordable treatment and rehabilitation. So many of the things, say, for example, 1 and 2, we have already done that for the NCD. So it is only picking and choosing some of the key elements for NAFLD. We were already doing many of this. So we can tweak little bit, say we can put in the app of ASHA, which is measuring the height and weight of the person. If we put another button for calculating the BMI will come out, so which could be useful for the NAFLD screening purpose. And then timely, affordable, accurate diagnosis. So we have got a battery of laboratory tests, and we have got ultrasound. We have got the physicians who are already well trained in the district hospitals. Now, if you put a fibroscan, say if you train some of the technicians for doing normal ultrasound with the focus on NAFLD, some of the things we can easily do that. Then access for affordable treatment. If we can prevent, that's okay. If not, then how do we treat that? So this is how we have started thinking. And the proposed promotion and prevention of activities are, IEC activities through the various meetings that we are having now, the international or the national health days being celebrated. And now, many of us are so sensitized that, whenever we have any health day, the liver comes into focus. So I think not just because that we have a new addition here, we are not celebrating as a new baby, which is to be celebrated, but realizing that, liver seems to be the center of all the NCDs, that if you take care of liver, many things will take care of themselves. So this is one of the many of the proposed activities for prevention of this thing. And this can happen at the various levels. The activities Asha is already doing is this one, and which I had already explained to you. And now the Asha's activity can little bit tweaked in such a way that they also know that they are also detecting NAFLD along with NPCTCS. And at the sub-center level, we already have a set of activities there, and some activities like we may emphasize more on the obesity than the pedal edema, which they have been doing in the sub-center for, say, pregnant mothers in the antenatal checkup, may now be adapted for NAFLD purposes. We are not teaching them any new skill. And then referral of PAC, then inclusion of NAFLD in patient referral card, etc. Some of the additional things which we are planning at the sub-center level. And at the PhD level, many of the activities are already there, and then we will try to build the capacity of the medical officer so that he is able to diagnose NAFLD and evaluate, advanced liver fibrosis, and then refer to the higher facility, which is at the CAC, with, of course, reporting at both the PAC and the sub-center in the Form 1 and Form 2 of the NPC disease, which we are also trying to do in MIS in the near future. Then at the CAC level, which is a little better facility, we have some activities under NPCDCS, and we propose some activities. Say, for example, we may want to add LFT and the CBC score, so that we have got what is known as the FIB4 score, and then we train the medical officer to utilize the services which is available, then tweak it in such a way that he or she is able to diagnose NAFLD here. So here the continuum of care from the ASHA, the ANM, to the medical officer, the PAC, to the CAC is now continuing, and we are including a liver report in the Form 3 of the NPCTCS. And now when we come to the district hospital, we should be able to offer some more advanced facility of management of NAFLD, like risk certification for advanced liver fibrosis if the facility was not there in the CAC, and for patients with indeterminate risk for advanced liver fibrosis, we should be able to perform enhanced liver fibrosis or what is known as the fibroscan. So we need to build the capacity here at the district hospital. The physicians are also available here. So in many district hospitals, it may not be possible, but I am also aware that there are many states with many progressive states where the district hospital facility is as good as medical college, that they are even upgrading it into a medical college. So the data recording will again continue in the form of Form 4, 5A and 5B of the NPCDCS. So the continuum of care is building up for NAFLD with little tweaking here and there, building on what is already existing for NPCDCS or any other program under the National Health Mission. And the medical colleges and the central institutes, they may be outside the realm of, outside the purview of the NHM, but then if we work closely with the medical colleges, we should be able to build the capacity in such a way that the risk stratification for advanced liver fibrosis can be built here. And for some of those patients with indeterminate risk for advanced liver fibrosis, we should be able to do a fibroscan, and we can build the capacity for doing that, and then also for the management of this liver, these days of liver at the medical facility. So the diagnosis and the management of the NAFLD, wherever available, can be done at the gastroenterology department, or at least in the medicine department of the medical colleges. And some of the central government institutes, we know that they are very advanced. They already have an advanced facility. But The linkages from what I'm concerned is till now we have the facilities here at the central government institutes or many of the advanced medical colleges. But here we keep on waiting for the patients to develop a very advanced stage of the disease and try to solve a problem which we are finding it very, very resource intensive with no definite outcome that we can predict, which of a disease now which we could have easily prevented by easy means if we had detected early at the doorstep or at least at a sub-center or at least at the medical officer. So we should see the whole spectrum together. We continue to develop what's there in the central government institutes and medical colleges, but we should also look back, look down to where these diseases could have originated at the doorstep when the ASHA comes knocking at the doorstep with the CBAC form. So this is the whole continuum of care which we want to take care of after looking at NAFLD. We hope to have a National Center of Excellence in future where national guidelines for diagnosis and treatment can be drafted. Then we can also design training manuals, capacity building of master trainers in a cascade manner. And then we can also develop toolkits containing IEC material where any one of us can also go in and link and download or use any of those material there. And we should also, like any other program, want to monitor and evaluate the NAFLD component, not just the NAFLD component maybe, but whenever we do NPCDCS monitoring and evaluation, we should have that component of NAFLD included. Then when we have a National Center of Excellence, the next step, which we think could be good for not just NAFLD, but for any other purpose, we should have regional or the state cancer of excellence where the NHM component, which is being done at till the district hospital, and the activities which is being done at the medical college level can be integrated, can be examined, and also can come up with regional wisdom of implementing the NAFLD component. We all know that under the NPCDCS program, if you consider just a risk factor like tobacco or oral health, or if you consider the whole of NCD, we understand very well that NCD is beyond health, and it involves multi-sectors, the multidisciplinary as well as multi-department. So in the in the NMAP, we think that now we need to look at NMAP with the lens of NAFLD and ensure that and make sure that the liver component is also there when we are taking care of the many components. So many of the strategies we already have in NMAP, and now when we are, these are all generic strategy areas and key outcomes. I am sure NAFLD is already there, but we need to have it, a secondary look how we can better implement this with liver in focus. So we already have many promotive strategies like the Fit India campaign, which the Prime Minister himself launched the Fit India appropriate fitness protocols for increasing physical activity for the different age groups. We also have the Eat Right campaign, which will have a bearing on the mental and the physical health, and this could also serve as preventive strategies for many of them NAFLD. So the way forward, which we see here, as I said in the presentation, is the proper media plan, inclusion of the operational guidelines in the NPCDCS, as well as the PIP guidelines that we have for the state, and then creating the FMR codes. This is for the state nodal officers, if required, or use the already available facility in the PIP, and we try to monitor through the program implementation plan. Then we also ensure equipment, diagnostics, and medicines for NAFLD, create capacity at various levels, monitor through the PBS, and we may start, in piloting in some districts. But as I said, piloting has a very limited role now. But if we had gone through together the whole presentation, I think we are at a very advanced stage of NPCDCS that many districts or many states can easily take this up. So this is what I wanted to share with all of you, with the hope that there would be many people who would be spearheading NAFLD, so that many of our NCD problems get solved at the nation stage, and then we don't need to invest so much on not just NAFLD, but also in other facilities like cardiovascular diseases and the CKDs, even to the extent of reducing our burden for end-stage renal disease, for which we require multiple setup for dialysis and cath labs and STEMI. We have so many of them line up, but if we take care of the liver, I'm sure many of them could be easily taken care of. This is what I wanted to share, and once again, my apologies for jumping the queue, and I'll hand over the mic to the organizers.